are the veins draining the cremasteric, the gubernacular, is that if those seriously are responsible for varicoceles, why are we not seeing varicoceles on the right? Okay, it makes no sense to me whatsoever. The other factor is the testicle's got to drain. It's got to have a venous drainage. Yeah. So if you block off the internal spermatic vein, then who's to say that the veins that you're seeing in the gubernacular or whatever are not just a normal drainage pathway for the testicle in a normal way? So until someone can explain to me why it's only on the left that you get these gubernacular or cremasteric vessels, then I don't believe it.
Can I come back to that? Yeah. So the explanation of why you get a varicocele is nothing to do with the extra anatomical drainage sites. I think that you get a higher hydrostatic pressure that causes these channels to then preferentially drain if you just ligate one or close off one thing. A bit like you develop collaterals. If you tie off a vessel, you'll get additional drainage pathways. So the point is that the reason you get varicoceles mainly on the left is partly genetic, partly anatomical, partly the fact that there's a 20% higher risk of having valvelessness on the left than you do on the right. So that explains why you get a varicocele on the left compared to the right. But when you get a varicocele, you get a raised hydrostatic pressure that might allow you to then preferentially drain through these collaterals that open up. We don't know for sure. There's absolutely no fact or data, but one of the new things that have come out from that anatomical study, what we didn't know is that the left side of the testicle also drains to the right system, which we never appreciated before.
Yeah, but it still makes, we know the argument for why we get varicoceles on the left. We understand that, but that's an internal spermatic vein argument. It is not a gubernacular, it is not a cremasteric argument. Yeah, and if you're blocking that off and you treat it properly, then there should be no reason why you get increased varicocele on the left compared to the right. I just don't understand that.
Yeah, I have to say I don't know the answer to that question because, there are some people who do microsurgery and don't bother to deliver, and I agree with Miles that doesn't seem to make much sense to me, but they quote success rates of still being very, very good. Whenever I've had failures from microsurgery, it's always been in cases where I couldn't get to the gubernacular vessels because I'd had a previous fixation of the testicle or something complex. So personally, I think the gubernacular vessels are quite important, but yeah, I don't know the reason why. Any questions from the audience? Can we have the microphones there? Just while we're waiting, I've got a question. Would you do something, because we've been speaking about which is best from the terms of fertility. When it comes to pain, I find it a bit more difficult sometimes because the guys, as you've said, who get pain after embolization, they are miserable. And it's really difficult to understand why they've got it over anyone else. And they get it really, really badly. But at the same time, if someone's got groin and testicular pain and you make a cut in their groin, sometimes it gives them a new focus point for their pain. So what would you do? Would you go for something different if it was pain-orientated versus fertility?
It's a difficult one. I don't think I'd like to say that if a patient has a dubious cause of pain, I'll send them off to have embolization. I wouldn't like to say that, but sometimes you have to set the expectation right for the patient, like in everything, and say to them that sometimes there are a couple of series that have looked at recurrence of pain following any treatment of a varicocele that range from 10% to 40%. So if you say to them that there is a risk that your pain may persist, and we may not explain it, and may neuropraxic neurological in origin, you've set that out from the very start, which I think is advisable and certainly what I do for all my patients.
Okay.
Question. Thank you very much. It's a good session from my andrology colleagues. Just two questions. In 2019, up until now, I'd still offer my patients the option of embolization or surgery and explain that they are equally effective and they have a choice. And they usually make their choice and they go ahead and have whatever they're going to have. That's my one. So am I wrong to do that? My question. And then my second question is, yes, I would share my consultant radiology colleagues' comments about, I don't quite get why it's good to remove every single vein from that left testicle, especially. I've seen one patient in the last 2 years who had microsurgical repair elsewhere, and he seemed to have a lot of pain. He seemed to have almost like a compartment syndrome in his testicle. What is the complication rate of this aggressive microsurgical varicocelectomy? That's my second question.
Do you want me to take that?
I've just one point on that is that the only time I've seen a problem with a testicle after a Bag's embolization is when someone used sclerotherapy and it went into the pampiniform plexus and they got venous infarction. And what I don't understand is if you strip all the veins out completely, how do you know that you're not, as was suggested, you're not getting some sort of venous hypertension or whatever in the testicle?
Okay, so the first question about you're stripping all the veins, but what you're doing is preserving the vas and its adventitia. So that's one of the things I've said is that you're not stripping the vas, you're keeping the vas and the perivas vessels, which allows you to have another drainage site. Now, I can't explain why that doesn't dilate up and you get a recurrence there. But what I can tell you is you don't get infarction because when you follow up the patients, there is a 5% risk of atrophy from injury to the testicular artery. But when you actually look at, certainly when I look at my series and other colleagues' series, I've never come across a venous infarction. I've never had a venous thrombosis. I've never had that. And certainly I see what you'd mentioned about sclerotherapy, but I've also had one or two patients who've had coils for embolization complaining of chronic pain. So I don't think we know exactly why people get chronic pain from whatever technique you choose. We've had patients who've had a standard hydrocele repair who get chronic pain. And again, we have no mechanism to explain why you get that.
Just coming on to the question about the circulation and the compartment syndrome, I have had one patient who's had a microsurgical varicocele ligation done who ended up with venous ischemia of the testis, not done by me, I can say, but he'd had a vasectomy done previously. So exactly as CJ has said, you need to rely on that vasal vessels as your return mechanism if you're going to strip everything. And if everything gets stripped and they've already had a vasectomy done where the vasal vessels have already been interfered with, they've lost that return mechanism and that will lead to venous ischemia. But it doesn't tend to be this kind of chronic grumbling pain. It will build up to venous ischemia, the testicle will die, and when you do the Doppler, you can see the arterial inflow in where there is just stasis within the testis. So it's classical for that, and they have to have orchidectomy.
Okay. We have a next question from the audience.
How do you treat children with varicoceles, and what criteria you depend to make your diagnosis? 1. 2, how do you diagnose recurrence, and when after surgery or embolization? What criteria do you take to depend, you said, for your patient you get recurrence?
If I can answer the first part of that question. So in children with varicoceles, one of the main issues is testicular development. So you have to look pre-pubertal, post-pubertal, slightly different. But under the umbrella of children, recommendations are to definitely treat varicoceles because they can have implications on fertility. There is evidence to show that if you do treat varicoceles in this age group, that it promotes better testicular development and henceforth fertility. And indeed, you do see patients who present at a later date into adulthood with a varicocele and a smaller testicle. And usually you ask them, when did you have the varicocele? And they'd go, I've had it all my life. So I think to answer the first part of your question, you definitely should treat children with varicoceles. The second part of the question is, again, lending itself to which is the preferred modality. Now, again, the studies with varicoceles in children are lacking, so you have to extrapolate the data and findings from the adult studies. And personally, I would say, I don't know what the rest of the panel would agree with, it does come down to the patient themselves, what sort of preference and mitigating risk. Any other thoughts?
I think it also depends on the setup in your health board. So in our health board in Edinburgh, there's a clear-cut line between pediatricians and us. So I tend not to get any of the patients referred to me until they've passed the age of 16. But they tend to have had varicocele since they were 13, and they've been observed or sat on. And I guess some of the data on the paternity, when it becomes more mature and solid in future, might allow us to address this earlier in this population. But we have an arbitrary cutoff that we tend not to see the patients until at least after 16, sadly.
Yeah, that's the same for me. I wouldn't see anyone under the age of 60.
I think there does seem to be about, among paediatric surgeons, a higher rate of doing laparoscopic approaches than we see in the adult population. They're still very much in favour of that. I'm not sure if that's the right thing to do, if you extrapolate what we see in adults. But really good question about recurrence.
Yes.
It'd be interesting to see what Miles' take is on that from a radiological point of view, because they'll be sent to you often to say, can you scan for a recurrent varicocele? Yeah, do you think it's enough to say just seeing it clinically, or is it on ultrasound? Do we have to define it by vessel size? What do you think?
I think this is the whole point. I didn't make my point very well when I was talking, but I mean the point is that we're trying to define something that on one hand is normal. Every man's got some veins around his testicle. On the other hand is some grade 3 varicocele, and at what point does it become pathological? My own theory is that actually if you take someone and examine them in a cold, do an ultrasound in a cold room, or you've got cold gel, then the diameter of your veins is going to be smaller, etc., etc. So I think this is a really difficult question, and we need to try and answer it. But the whole point about this is none of this. We talk about recurrence, right? The recurrence rate is this, but how are we defining recurrence? And until we can do that, we can't do it.
What about the Doppler ultrasound scan, the length of the reflux and the diameter of the vein?
Yeah. I mean, on other talks, I've gone into this great detail, but there are we look at diameter, but you can read papers that they take anything above 2, they take anything, some people take 8. You can look at reflux and the length of the reflux, how long it's refluxing for. People have come up with scoring systems, so you have a clinically significant varicocele if you have a score above so much. The answer is, we really don't know, and we're trying to debate something that actually we can't even define. So it's to my mind, it's a bit silly.
Okay, but we have another question.
Sorry, excuse me if I missed what's already been said. I came in a bit late during the first talk. So I have 2 questions. First of all, the number of men with hemiscrotal pain and a varicocele exceeds the number of men whose pain is caused by that varicocele. So what characteristics would the panel focus on in deciding if they're going to treat the varicocele and attribute the pain to that? And the second question is, common scenario, you get a 16, 17-year-old lad who comes in just after the growth spurt with an anxious mum, with an asymptomatic varicocele, which they've Googled, normal testicles and examination. How do you advise them and follow them up?
Shall I take the second question first? I'll take the easy one. The 17-year-old with the varicocele, growth spurts past, they're still in theory adolescent, and you can argue the testicles are fully formed. I think also in the 17-year-old, what's important is, they're going to become sexually active, if not already sexually active. I think if it is a symptomatic varicocele, not necessarily in terms of pain, but either visible or palpable, I can guarantee you that 17-year-old would want it fixed, because at that age group, they're quite insecure about their bodies. And I think it's important. Sometimes you do get extremely mature 17-year-olds who look at it. From my point of view, a good starting point would be semen analysis. Sometimes the answer becomes obvious. If the semen analysis is abnormal, then you would fix it. A lot of times, the majority of these cases, the semen analysis would come back normal. So then I allow the patient to make an informed decision. I give the exact facts. The fact is, although the semen analysis is normal at age 17 with an ongoing varicocele, it may not necessarily, it's highly likely it will become abnormal. And usually that sways them to make the decision. First question?
Slight thing I would say with that is, if I see someone in that scenario, I would do semen analysis if it's appropriate to do so. Some of them, you look at them and it could be a less mature 17-year-old versus a more mature. I don't think it's very fair to ask a less mature 17-year-old to give a sperm sample. Some of them will just give you funny looks, and then you just know that's not appropriate. But if they have got normal semen analysis, I take a slightly different view. I would offer them no treatment and then say we should just survey you. Just repeat your semen analysis in a year. And if it's getting different, or if serial examination is changing, then I would go in and do treatment. So you do this kind of adapted strategy for jumping on it when you need to and not otherwise. With regards to the pain, that is a really good question. I think that is the kind of $64,000 question. What is pain attributable to a varicocele? You get some of those classical patients where it's that chronic, aching, gnawing discomfort, end of the day, only when they're standing, goes away when they go to sleep. I get very suspicious about guys who say they wake up in the middle of the night with the pain. I don't think that's varicocele related. If you examine them and it's tender, I don't think that's varicocele related. And so it's kind of like being a detective. You've got to convince yourself that the patient sitting in front of you is giving you symptoms from those veins. And if I can't convince myself, I'll just tell them quite frankly, I don't think I'm going to make your pain better. And I will change the counselling process and say, where I think your pain would have got better in this percentage, I think it's way less. And it's up to you if you now think the risks of benefits versus the complications is no longer worth doing that treatment. But worst thing you can do is treat them when you're not convinced, because when it fails and they come back with that radiological small varicocele, I've seen plenty of guys like that who are now on their 5th or 6th procedure being referred for a redo microsurgery for one vein, and they've become fixated that it's from that varicocele, because that's what they were told when they were 15 or 16. And then suddenly you sit in front of them and saying, it's not that anymore. It may have been, but it's not that anymore. And they look at you like you're an absolute nut job because they've had 10 years of misery trying to get rid of that pain. You've got to get it right.
And I think, so for me, when I first started, didn't realise I was getting dumped on, but I obviously was. And I get sent a lot of these patients. So it was a bit atypical, and I thought, well, actually, there's no harm in doing this because it's really minimally invasive. And I tell the patient, actually, I don't think it's this, but if we do this and it makes it better, great. If it doesn't, there's no real harm done. But I do find that they are a particular subgroup of patients, and they are the ones that if they're going to get bothered by coils, they really, I've had one patient, and there's always one patient that sticks in your mind who was just, the coils are terrible and they've ruined my life. And hence, I am changing my practice now, and I'm using more sclerosant, so there's nothing left in the patient.
And I think there has to be some kind of buy-in with our radiologists as well. Instead of it being a clinician making a decision in the clinic and then sending them off for an embolization, and it's almost like you're just doing the procedure without being involved in that discussion beforehand. That's not the right approach. So much of interventional radiology now is as involved as anything that we do in surgery. And there should be this process of interventional radiology, we've spoken about this before, seeing patients beforehand, making the diagnosis, thinking it's the appropriate treatment, seeing them post-procedure to follow things up as well. Not just one of those things that's a nameless, faceless person doing a nameless, faceless procedure, and they may not have agreed to that indication to start off with. We've got to change what we do. It's not right anymore. Interventional's changed.
Okay. And just one more point coming back to when I've looked after the 16 or 17-year-olds sometimes they're accompanied by their mother, and if you then have a discussion on the asymptomatic varicocele and the potential for fertility, often it's the parent or the child who wants to know a little bit more and might be willing, they volunteer, should we check the fertility or semen status, and that might give you a gauge as to where to go. And again, there's data from Turkey showing that if you treat these patients earlier, you might preserve their fertility long term.
Good. Brilliant. We have a lot of questions coming through on the app. A question that follows up nicely, a question from Miles. What would you do? What would you say to a patient who is insisting on coil removal for post-varicocele embolization pain?
Well, the way I consent all my patients now is that I tell them that the coils are permanent and they cannot be removed. Okay, so that's what I say beforehand. There's one patient who sticks in my mind. Actually, I was lucky. He actually had an inguinal hernia, had that repaired, and his pain disappeared. So that got me out of jail. But I know, from the web, different websites there are about coils ruining my life, that there are certain surgeons dotted around the country that will take those on, and then maybe some in this room. But it is, it's quite an undertaking to take coils out. It's a big operation. Yeah. But it can be done, but I certainly don't, I'm very clear when I do an embolization, when I consent someone, these coils are permanent.
Is there anyone in the room who does take out the coils or has experience of doing that? Difficulty. Have you found it effective, Chris? No. Yeah, that's interesting to know. I'm not sure if it's the coils that's causing the pain or if there's some kind of perivasal irritation that they get or fibrosis that they get.
They get a type of pain syndrome.
Yeah.
When you remove the source, it doesn't actually get rid of the symptom.
You've done that laparoscopically, if you're just stripping out the vein. It's interesting. That's what.
From a radiological point of view, obviously it's interesting in that we put coils into people for lots of different reasons, into lots of different bits of their body, and none of them get pain. But,
It's a question from the back.
Yeah. Can I ask about vasectomy after microsurgical varicocele surgery? Do you warn them that there's a risk of venous infarction? Do you give them a time limit to allow collaterals to form? Or is it risky at any point after microsurgical surgery where you've tied off all the veins, or conversely after non-microsurgical surgery where you may have damaged the artery. Is the advice not to have a vasectomy at all after this surgery, or what? I don't see much written in any of the BAUS guidelines.
I think that's an excellent question. An excellent question usually means I don't have a bloody clue to the answer. But, thing is that you never know the op notes either when you're seeing someone years down the line. They may have had their microsurgery done somewhere else. But generally from that principle that they are relying on the vasal vessels for their return, I wouldn't touch them with a barge pole. Like I said, the only patient I've had or seen troubles in had a previous vasectomy, so I wouldn't want to go back in and touch anything in the cord. So personally, I would say it's something to avoid. Personally, I don't know anything about timescales. I don't know if anyone else does.
So I've only had one patient who requested a vasectomy at the time of his microsurgical varicocelectomy, which made it easy because what you could do is go directly onto the vas, preserve the adventitia, and just take that segment of vas because it was right in front of me. However, I think I take on board what you're saying, and I don't think there's an answer to that, and you've got to warn them. A bit like a vasectomy after orchidopexy for undescended testicle, that it may cause a reduction in your blood supply.
Wow. Okay. Another question from the app.
Venous collaterals likely to be inguinal canal. If you do scrotal vasectomy, that should not interfere with the venous return.
Yes and no. I mean, because you've taken the vessels closer to the end organ, haven't you already? So you've disrupted the downstream flow already. And so, if you were then to nip off the vasal vessels at any stage, it could end up leading to trouble still.
Okay, question from the app. Does every man with an ultrasound found varicocele need a semen test? How I would approach that is twofold. One, depending on the severity of the varicocele and what the testicle feels like, so depending on the examination findings. And then again, it depends on if fertility is an issue. If he's had 4 kids like Miles and doesn't want any more kids, then it's a non-starter. If he and his partner have been trying for a couple of years, then yes, definitely. So I would take that on a case-by-case basis. Would anyone do anything differently?
Yeah, I mean, I personally think we don't do enough tests of testicular function. If someone's come to you with a problem which we know can affect function, why aren't we checking function? We should check the testosterone. If you want to go for the wider thing, there is some evidence of varicoceles affecting testosterone levels, but certainly I think you should check the semen analysis. And I remember, again, everyone always has that one case that sticks out in their mind. I saw a patient privately who wanted to have their varicocele treated, and I was insistent that he had functional tests beforehand, and he didn't want to because he was about to get married. He didn't want to have any kind of negative semen analysis hanging over the nuptials yet to come. He ended up doing it after a lot of persuasion, and it turned out he was azoospermic. Now, he actually had no atrophy of his testicle, a normal contralateral testicle, a grade 3 varicocele on the left-hand side, and I never would have guessed that he had azoospermia. It ended up totally changing his kind of concept of having the treatment done. We did do the treatment, and he's had a baby now 18 months later with natural conception. So it ended up being good news in the end. But I never would have guessed that would have been the case, and you can't assume everything's normal just because the contralateral testis feels okay or looks okay on the scan.
But in his case, his azoospermia would have been secondary to something else, not the varicocele.
No,
so
I disagree.
Okay.
I disagree.
I disagree as well, because I've had patients who've had azoospermia referred to the infertility
With
unit
single-sided varicocele.
with a single-sided, and I've corrected it, and it's just reversed them back to.
Yeah, I would totally say the same thing. We've had lots of patients from azoospermia, single-sided, grade 3, treat them, and they get back to near to, and his counts went back to 10 million.
All right, I've not had that. Good.
So that's again why we need to come up with some better way of these, because 15% of all men have got a varicocele. Not all of those have fertility issues. So, what is it? Is there something in the testicle that we could image? Can we do elastography on the testicle? What can we do that tells us the ones where the testicle is suffering?
Can we just get those last questions up again, just to ask people's opinion now at the end of the session?
And while we're doing that, just one final question before we wrap things up. In most EGHs, microsurgery is not available. What's the best option? Should we refer to a regional centre? I think the answer to that would be probably not, because then we're making a decision that we should just do microsurgery, and that's not the aim of this session and what we're trying to decide. I think there is some evidence that microsurgery probably has slightly reduced risk rate for testicular atrophy. However, I don't think the evidence is robust enough to recommend not doing non-microsurgical techniques.
Okay, so just to wrap up the session, just the same questions as we had before, just to see if the session has crystallized or changed your approach to things. So same first question as before, relying on ultrasound or on examination. So just vote via the app now. So same, okay. Didn't think that would change. Next question about treating the infertile male with abnormal semen parameters and a clinically relevant varicocele. There's been some bonus. It's amazing. I teach on the FRCS course and for infertility, and over the last 6 years, it's gone from when you ask people in the room how many people would treat varicoceles if they were clinically relevant, and that was at the time of the EAU guidelines from 2012. No people put their hand up in the room, and now when you teach on the FRCS course 6 years later, everyone puts their hand up in the room, and it's a real change. That's good to see there as well. And then the last crucial question, what are you going to go for? Oh, look at that.
Oh my goodness. That's bad. Well done, CJ.
That was a surprise to me, Miles. Well done, CJ.
So, I mean, just to say that there is, like there is in many aspects of medicine, there are many knowns and there are still many unknowns as well. And as Roland was mentioning before, everything always ends with a good concept of a trial to walk away with. And in fact, this is a trial that we are setting up, or are very close to finishing setting up, as a national trial from guys in UCH looking at varicoceles, clinically relevant varicoceles in fertile patients. Which one is better, embolization versus microsurgery? And we're going to be tackling lots of the things that you've heard about today. How do you diagnose it? Lying and standing examinations, ultrasound, warm room, standard temperature for gel. We've got to get the kind of diagnosis right. We've got to get the follow-up right. And then we can answer the questions about the treatment. So watch this space. Thank you very much. Have a good day.
Thank you to our speakers.